Thank you so much. Very good morning to all of you. So I'll be speaking on a new trifocal IOL, no financial interest. So what are the challenges in multifocal IOLs that we have today? One is patient selection, IOL selection, patient counseling is very important, and you need to be extremely precise in your biometry as well as in surgery. So what we do in our setup is basically repeat readings are taken for all these patients, ensure that the readings are taken on virgin corneas before any anesthetic drop or a applanation tonometry is done. Proper ocular surface assessment, topography, OCT macula in all these patients. Also look at the pupil and angle alpha. Now, as regards astigmatism, we just put in the K1, K2 on the Barrett toric calculator and then decide whether the patient needs a toric multifocal or not. Yes, you can also discuss the other options with the patient. But all of us know that like an ideal husband, an ideal multifocal IOL is also a very elusive thing. So all you need to do is, in order to choose what lens is best for your patient, you need to be a matchmaker. So you need to communicate to the patient, explain to him what you are going to give, understand what are his visual demands, expectations, and then what we do is basically ask 3 questions. One is the computer work. Here we are representing intermediate division with the computer work. How much of reading he does per day and what is the amount of night driving does he do. Now if somebody is doing daily night driving, then definitely we would avoid trifocals and even some ADOFs who would probably end up having glare and halos. So their advanced monofocals or monofocals would be the better idea. Some patients who feel that glare is acceptable to them, then you can go ahead and ask the next question as to how much of intermediate vision does he require. So suppose he is a computer executive who requires 8 to 9 hours of computer work, definitely you have to address intermediate vision. So either you give him a trifocal or you give him an ADOF, and if he also wants near vision, you can explain micromonovision to him. Also, you need to understand that many of these ADOF lenses who give only intermediate vision, you have to explain to the patient that he requires a reader, and whatever is the reading distance of the patient, what we do is, we give him an inverted paper to read and then see at what distance does he require the reading material. So do not over-promise all of these patients and also take an extra consent from these patients. So today what we have been using is the RayOne trifocal platform. So it's a 6 mm optic and aberration neutral aspheric lens, which is totally preloaded, has a 12.5 millimeter overall diameter, 0 glistening, and because of the aberration neutral aspheric optic, it gives a very good clarity and contrast sensitivity also. Also the number of rings are just 16, the central 4.5 millimeter is the diffractive zone, and beyond that you have the distance zone. If you look at various diffractive trifocals, so we know that whether it's any kind of diffractive IOL, there will be some amount of loss because of constructive interference. So here we have the minimum loss at around just 11%. The distribution is 52% for distance, 22% for intermediate, and 25% for near. Important thing is it's glistening free. So because of this, if you compare it with many of the lenses, affecting the quality of vision is minimum. So here we have a case where we are going ahead with a femtolaser assisted cataract surgery with a premium lens. So most of these patients, especially here we are doing a RayOne trifocal toric lens. So with a premium lens, a premium technology also is offered to the patient, and you have to go through each of these steps absolutely meticulously. So even though it's a flax procedure, there is a pneumo delineation. So you just ensure that the nucleus rotates well, superficial cortex is removed, and meticulous phacoemulsification is done. In these flax patients, irrigation and aspiration of the cortex, you have to be careful because they are vertically cut fibers. So this is the RayOne preloaded lens. You inject viscoelastic, and then from both the sides, you clip in the top cap, and you can see how the Rayner procedure is done. Here you can see the rings, and remember, for all these cases you have to wash off the viscoelastic from underneath the lens also. Moreover, because it's a toric, and also the reason is because this has an Ammon apple 360 degree square edge. So even if it was not a toric, because of this square edge, it gives a very good rotational stability, but you have to wash out the viscoelastic from behind the lens. Now one of the important features are, it has an excessive wider contact angle compared to the other lenses, and it has a very good anti-vaulting haptic procedure also, because of which there is a good rotational stability. and very less yak capsulotomy rates, just 1.7% at 24 months. If you compare it with the other trifocals, it's absolutely comparable. You can see the light distribution as well as the near ad is around plus 3.5 for near and 1.75 for intermediate. This was compared to the Zeiss 80 Lisa. You can see the defocus curve is absolutely comparable. There are a lot of clinical papers comparing it with the panoptics as well as the fine vision lenses. So this was another comparison with the fine vision as well as the accuracy of panoptics and with the 80 Lisa. So all in all these trifocal patients, you have to ensure that the patient has realistic expectations, take special consent, explain to them also about neuroadaptation. If the patient is dissatisfied, it's very important to understand what is the reason. Some of these times you may have a residual refractive error, poor ocular surface. Look at CME post-op at around 3 weeks. And also remember that these patients have to be very given good chair time pre-operatively. So a premium trifocal IOL is easy, safe, efficient, reliable, consistent, and reproducible, and RayOne has given us excellent results.
Thank you, madam, for a concise and specific presentation.
Thank you.
I noted that more than 1.5 minutes of your presentation was involved with the counseling of the patient, and that is, of course, important. It's under promise and over deliver. So I like that concept of near reading, like 40, 50 centimeter, tell the patient to hold and read it. So it's right. If we do it properly, then it turns into a jolly affair with the patient. Otherwise, if we don't do the counseling proper, I think it turns into a responsible marriage then. No questions? Is there any questions?
Dr. Anagha, especially you said we should wash off the viscoelastic behind the IOL. Would you not advocate hydroimplantation in these lenses?
So if it works
I have
well
been
in your
using
hands,
these lenses
yes,
a lot,
yes.
and they are very, when a patient is very happy,
Yes,
but
you
I
can
do with
definitely do.
hydroimplantation.
But for those who are using viscoelastic, you need to wash it. But in spite of that, the capsulotomy rates are really very less. That's because of that 360-degree Amon apple square edge also.
So we call upon
Thank
the
you.
next-
Thank you so much.